Yes, good evening, everyone, and thank you very much for joining us for our weekly webinars. We really appreciate you for always taking your time to join us on a weekly basis. Today's topic, we are going to discuss hypertension in COVID-19. This is clinical care webinars, which are hosted every Tuesday between 18 hours and 19:30. I am Dr. Lesego Mawela, and I'm one of the co-founders of this particular platform. This is the outline for today's session. I'm just going to say you are welcome, but I know that my colleague, Dr. Segola, is going to do a better job at that. Just to say that if you are joining us for the first time, this particular platform exists to improve patient care through educational resources and evidence-based education, with the ultimate aim to enhance clinical practice. So our aim is that once you learn from these webinars, you are able to translate this to practice such that your competence and the competence of the other core workers is actually improved. I just want to share with you some of the key updates, just to say that please note that it's very important that when you register for these webinars, you use your full names correctly, because if you misspell your details, your certificate is likely to come out as well with those misspellings. I've had a number of inquiries, people saying I didn't get my certificate. Remember, if you spend less than 60 minutes on this particular webinar, we can't allocate to you a CPD point. We might give you a certificate, but it will be without the points. So we generally measure and track. Even if you log in and out several times, we will usually combine all those logging ins and outs. And if they make an hour, you would be eligible for one CPD point for each hour. If you are attending as a group, it's not possible to issue certificates to a group. So it's important that every person registers individually. An important update is that we are working on a number of training programs, some of which we thought would be ready by now, but it's still work in progress. We do have now the live virtual dispensing workshop, which we are going to host this coming weekend. So if you are still interested, you have until tomorrow to register. We have had over 300 people doing the HIV management free course. I see we are getting inquiries for more people who want to enroll. So I'm checking that whether it's something that we can continue to do, and then we will update you before the end of this week. Later this week, we'll also launch the clinical management of drug-resistant TB. So if you are interested to learn more about TB, please be patient. That particular course would be out with all the allocated CPD points for you to consume. We are working with a number of specialists to work on preparatory courses for the diplomas, but also for those who want to do their part ones and those who want to prepare for part twos. If you're already a registrar or you are planning to become a registrar, you would really find pleasure. We are also working with our colleagues, including Dr. Masina, who's going to present today, to work on a comprehensive course on the clinical care for patients who might be infected with COVID-19. You must have seen an announcement that we want to encourage you to support, the platform so that we can continue to do this great work that you are doing. Please visit our website and register yourself as a member to support the program. When you register, you've got two options. You either take up a 1-year subscription or a 2-year subscription. These subscriptions would really help you to achieve your regulated CPD requirements, including your ethics programs. And you would see that on a week-by-week basis, we are now launching new courses. So you'll be eligible as well for great discounts if you are a member. In the new year, these webinars will continue to be available to you, for free. So we won't limit access to these webinars. However, only members will be eligible for certificates and CPD points, because to maintain the platform, we really need your support. So do take some time to join us and be part of that. These are some of the benefits you will get as a member. You will be able to meet all your CPD requirements. You'll save a lot of money because really our subscription fee is like 1,000 rands or so really for the whole year, which is not a lot. You'll be eligible for quite a number of discounts. You'll also enjoy members free courses like the HIV course, which the guidelines course, which most of you have enrolled, you have received your certificate, so there's going to be more and more of that. And we are working on developing new content such that you'll have a huge library of clinical topics that we would want you to really enjoy. So we hope that you visit our website, www.clinicalcareplatform.com, and choose either a 12-month or a 24-month subscription and really support us to continue to do this work, but importantly, for you to gain maximum value from this. Just know that next week on Tuesday, we are continuing. We've got Dr. Madua, who is a specialist physician, who's going to talk to us about diabetes mellitus in COVID-19. He's also part of some research projects looking at this particular topic. He's going to share a number of case studies with us. I have listened to this talk and I encourage you to be ready to really engage with this particular topic. For today, I want to hand over to my colleague, Dr. Joshua Segola, whom we work together really to make this platform a success. Dr. Segola is an old friend of mine, but importantly, he's a specialist ENT surgeon himself. He's involved in research in COVID-19, but also in terms of programmatic response to COVID-19, supporting the Mpumalanga province and the Witbank Hospital. He's back from his sick leave, but he now broke his leg, so we wish him speedy recovery. Dr. Segola, you may take over from here. Thanks.
Thank you so much, Dr. Mawela, for such a warm welcome. I must say it's good to be back. I hope I did not miss much in the last 2 weeks, and we really welcome and appreciate the platform. Yes, indeed, it's the most effective and the powerful way to educate, learn, and to share knowledge. Keep it up, the clinical care platform. It's exactly 18:08. We have at least about 174 in attendance. We hope the show will last for about an hour and a half, hopefully not beyond that. And I believe we all know the house rules. Good evening to my panelists and everyone in attendance. You are most welcome to tonight's seminar. It's been said that hypertension is extremely common in SA and contributes significantly to the burden of non-communicable diseases, with an estimation of about 13.5 to 75% in the region of being uncontrolled in SA. And we also have seen the prevalence of hypertension increasing in the last decades. And we know that hypertension is a major risk factor for cardiovascular diseases, and casually it's been linked to strokes, myocardial infarction, renal failure to some extent, and peripheral vascular disease. However, today we're talking about hypertension in COVID, and there's been a growing data from US and China, and also showed that there's a high risk of COVID-19 complication in people with hypertension. Colleagues, to unpack it for us this evening, let's give a warm welcome to a friend and a member of our clinical care platform, Dr. John Masina, who's a specialist emergency physician and also a WHO consultant in case management of COVID-19. Thank you. Dr. John, the stage is yours. You may share your slides.
Thank you. Thank you so much, Dr. Joshua. Thank you so much, Dr. Mawela. Good evening, everyone. And thank you for coming to this clinical webinar. And I hope I'm loud and clear to everyone. And we're going to have an interactive next maybe 45 minutes to 1 hour, and then we can have discussions after that. I'll switch off my video just to enhance the connectivity with the audio, and then I can switch on the video whenever needed. Dr. Mawela, thank you. Over to you. You can start sharing the slides, and then I can go through. Great. It's always an absolute honor to be with everyone around here, and I think I've enjoyed most of my time in Mpumalanga. At the moment, I'm in KZN, helping with the training that is going on in KZN. So I'm presenting from KZN, but I'm very much in Mpumalanga. So yeah, as introduced, my name is Masina John. I'm part of the WHO team in Mpumalanga, and also at the country office under the COVID-19 response. I'm under case management. Thank you. So yeah, I think Dr. Joshua has really put it in real perspective. Today, we just wanted to look at the hypertension in COVID, just the different clinical presentations of COVID-19 in hypertensive patients, and also the ambulatory care management of hypertensive patients. We will try to touch a little bit on the principles of management of complications of hypertension, especially in patients with COVID. And then I'll try also to give an update on the role of SE inhibitors and ARBs in the COVID-19 patients with hypertension. Next slide, please. Thank you. Just a brief definition, and I think most of us are aware with this. We know that it's a persistent elevated systolic blood pressure of more than 140 and the diastolic pressure of more than 90 millimeters of mercury in a subject aged over the age of 18 years and above. Systolic blood pressure, we know it's a pressure that is being exerted when the heart is contracting or in systole. And then the diastolic pressure is the pressure that is exerted when the heart is relaxation or diastole. And this is most likely just because of the recall of the blood vessels to push the blood back to the heart. Next slide. In terms of epidemiology, and I think this is where things now become very, very important. So we've seen that ovary, and I think Dr. Joshua has tried to put it into perspective. We've seen that ovary, approximately 20% of the world's adults are estimated to have hypertension, especially in the sub-Sahara. That's where this problem has been so much. We've been estimated that about 77 million and will be about 150 million by the year 2030. And if you look at it, the year 2030 is very, very close. We only have about 8 years remaining to reach. And I think we must have reached this target already. You can imagine with all the underestimation that has been going on with all the numbers that we have. And in sub-Saharan Africa, patients are likely to be younger. They've got more aggressive hypertension. That's why we see most of the complications. And usually they present late with a lot of complications. Next slide. So the impact of hypertension really is that they were estimating that about 7.5 million deaths, and that's about 12.8% of the total deaths that usually occur. And hypertension is the main driver of cardiovascular diseases. So it's one of the leading cause of non-communicable disease death in South Africa. That also accounts to about 57 million disabilities in terms of adjusted life years. And this becomes very important. And imagine for every increase of 20 millimeters of systolic millimeters of mercury in systolic blood pressure, or maybe about 10 in the diastolic blood pressure, that doubles your risk of having a heart attack. Okay, next slide. So globally, there's been an estimate that, and these were projections. I think these projections were made in the year 2000. And now we're talking about the year 2025, which is very, very close, which is just like 3 years from now. They were estimating that about 29.2% of the world's adult population will all be hypertensive. That's how common it is. And about 1.5 billion adults will be affected with COVID at one time. So you can imagine. But if we think about it, again, due to the underestimation and also due to the numbers that we don't know about, we might have already surpassed these targets by now. Next slide. Great. This is actually a very good slide. If you talk, we ask ourselves, why are we talking about the same old thing? I mean, it's been there for a longer period of time. Why are we still talking about it? If you look at it, you find that about 67%, there's an increase in hypertension between the year 1990 to 2010. There is a 67% increase. That's huge if you think about it. 18% of the deaths overall are caused by high blood pressure. 40% of these deaths are people with diabetes, and it's caused by high blood pressure as well. There's a risk of death in 2010 estimated to cause over 500,000 deaths and 10 million years of life lost. So they counted about how many people will lose their job, how many people will be stroke, and how many people will lose productivity just because of hypertension. And they estimated like 4 in every 10 people globally have hypertension by now. So it's really huge. It's really, and this is just hypertension before we start talking about COVID itself. Next slide, please. I like this slide. This is actually the prevalence of hypertension in South Africa. So I tried to go global and then I can narrow it down. So I found these 4 studies that were done actually in South Africa to just look at the prevalence of hypertension. And actually to complement this is that one of the MNED projects that I actually worked on with was looking at the causes of renal failure in an emergency department. So we did an audit of renal failures in an emergency department. And we found that 40% of the patients that were coming into an emergency department were actually, with renal failure, were actually secondary to elevated blood pressure. So it's really, really huge. So Stan, Basu, and the other friends in 2013 and 2011, they looked at the prevalence of hypertension in South Africa, and they found really huge numbers. Look at the patients that are over the age of 50 years. They were almost 80% overall prevalence in patients that are more than 50 years old. So you can imagine how huge this burden might be. Next slide, please. All right, this is also another great slide that I think we should also focus in when it comes to hypertension in South Africa. Look, if we took a total number of hypertensive patients to put them at 100, and then we look at how many are screened, we only find that in South Africa, we can only manage to screen about 48.7%. And out of those 38.7% that we screen, only 23.1% of them are screened but undiagnosed. And then only 5.8% are diagnosed, but they are still untreated. And then you find that the ones that we treat and they're under control, they are only 13.5%. Those that are treated but uncontrolled. And the ones that we control, we manage to screen, we manage to diagnose, and we manage to control is only about 8.9%. You can imagine the huge gap of 91.1% of unmet need. These are the patients that need management. These are the patients that need control. And these are the patients that we need to look out for. So you can imagine how many are out there with hypertension that don't even know, they have not even been screened. And to make matters worse, they are not even on treatment whatsoever. So it's a huge burden in South Africa. So what's the South African burden so far? So the World Health Organization has estimated that the burden of NCDs in South Africa are 2 to 3 times higher than what is found in the developed countries, in America, in all the UKs and everything, because we've got a huge burden in the non-communicable diseases. And in South Africa, the burden of NCDs is actually increasing. And between 2006 and 2015, it was estimated that most of them, actually, there is a huge cost that is going to government on management of these patients. Over $1.8 billion is being spent just to manage patients with diabetes. You can imagine about the amputations that are done. You can imagine how we distribute the drugs. You can imagine how much money we spend on buying these drugs. And you can also imagine how many CT scans have been done on patients that have got a stroke. It's a lot of money. Maybe even this 1.88 billion is just an underestimation as well, because we still have a lot of underestimated costs that we've seen. And then in 2015, 2011, South Africa agreed to introduce a global action plan that aimed at prevention, control, and decrease premature NCD mortality by at least 1/3. And this is what we are looking at. But remember, this was in 2011. That was pre-COVID. Now, let's look at the picture when it comes to COVID. Next slide, please. Okay, so before we go there, let's have a poll question. Dr. Mawela, over to you, sir. Okay, so the poll question is, which one is associated with high in-hospital mortality in COVID-19 patients? It's a single choice. Diabetes versus hypertension. Let's see how people go. We can give, I don't know how long we can give Dr. Mawela.
30 seconds, I'll stop shortly.
Perfect. Great. So far, it looks like 50-50. You know, 50% of people are saying, diabetes. The other ones are still saying, hypertension, man. But I mean, let's see how it goes. All right, good. Let's go to the next slide. And it's great. If we have a 50-50 chance, that's good for us. I'll give the answers as we go. Okay, so COVID and hypertension. Now I'm looking at the burden that hypertension has caused, but what has COVID now done to this burden? So patients with COVID-19 and pre-existing cardiovascular have an increased risk of severe disease and also death. And I think Dr. Joshua also touched on this. Infection has been associated with multiple direct and indirect cardiovascular complications, and we know this. You know the steroids that we're giving these patients. You know the myocarditis that COVID causes. You know the arrhythmias and the venous thromboembolism that COVID has been causing. All these are added to what hypertension can cause. Because hypertension on its own can cause myocardial injury. Hypertension on its own can cause arrhythmias. Hypertension on its own can cause venous thrombosis as well, because to damage to the endothelial lining of the blood vessels. And also the therapies, the side effects of the steroids that we're giving in COVID also concomitant to the effect of hypertension. And also just the response itself. We've been so comprehensive about triage of patients with COVID, but we've neglected a lot of non-COVID patients. And this is where the problem becomes in. And also just the provision of cardiovascular care may have placed the healthcare workers in a position of vulnerability, and they become hosts or vectors in terms of the virus transmission. As much as you want to take care of patients with COVID, you end up, or taking care of patients with non-COVID diseases, you end up being a vector, because you are coming from COVID patients to a non-COVID patients, and you end up infecting them as well. Next slide, please. So patients, and this we've talked about, up to 50% of hospitalized patients have a chronic illness, and 40% of them have got cardiovascular diseases or cerebrovascular diseases. And individuals with cardiovascular diseases are associated with risks such as hypertension, diabetes, and smoking. I've got a higher risk of severe disease and even death. And this is what we've seen. And according to our data, next slide, please. Okay, so we've seen there were like two big studies that were done in people living with hypertension and also people living with diabetes, about 58 to 48% and about 22 to 31% of patients. And we saw a huge mortality from COVID-19 in patients living with hypertension, with a significant increased risk of dying. Actually, if you look at the data from Mpumalanga itself, you're going to find that about 64% of patients that died in the mortality audit that we did and in 4 hospitals, it actually showed that these patients were actually hypertensive, and only about 46% of these patients were diabetic. So what we've actually concluded is that most of the patients that come to the hospital with morbidity actually do have diabetes, but the ones that end up having a mortality are the ones with the hypertension. So there's a strong correlation between mortality and hypertension as compared to diabetes. So actually the answer in that poll question was that hypertension. Hypertension has actually caused more mortality compared to diabetes in COVID patients. So and then it's obvious known, because most of the patients that are diabetic are also hypertensive, but it's not necessarily those that are hypertensive can be diabetic. So hypertension has actually been a bigger threat in terms of when it comes to mortality in COVID patients. In addition, various studies have shown that obesity is also a single independent risk factor for mortality in COVID patients. And this is just a meta-analysis that was also looking at it, hypertension in association with increased mortality and severity of disease in COVID-19 patients. This was done by Prenata. So Prenata looked at all the risk factors, and then they did a meta-analysis. They looked at all the studies that looked at hypertension and COVID, and they found that there was a strong association between hypertension and mortality in COVID patients, and all their forest protein were all above the risk ratio of 1. So you find that there is a strong correlation between mortality and hypertension in COVID patients, and that's why I think we are here to discuss it. Of course, and I think these are straightforward things that we all know. What are the risk factors of hypertension? We know about the age, the race, the family history, the overweight or obesity, and the physical inactivity. And these play really a big role. And I'll come back to them, I think, when I come to management. And I think we can still go through them in our own time. But next slide, please. Great. So we know about tobacco, high dietary intake of sodium, which is actually the biggest issue when it comes to our African race, because apparently we're taking more salt as compared to the other races. We've got low dietary of potassium, vitamin D as well. There's a risk associated with low vitamin D, and also high and alcohol consumption has also been the biggest issue here. And then stress as well. High levels of stress have been part of the issues in terms of temporary increase and leads to a temporary increase in blood pressure. Okay, let's take a pause and allow Dr. Mawela to give us another poll question. State whether this statement is true or false. There is a significant discrepancy between COVID-19 mortality and excess mortality data in South Africa. Is this true or false?
Um, 10 more seconds. Let's all participate. Thanks.
Great. This is also another very good question. And so people are saying this is true. About 79% have said this is true. And about 21% are saying maybe there could be, maybe there's a correlation, yeah. But I'll give the answer as we go. Next slide, please. Great. So imagine all these things that have happened. We've done a lot when it comes to COVID response. So we've gone flat out. Let's look at the COVID. Let's see how we can sort out the isolation centers and the bed capacity and all those things. One thing that we should remember and always remember is that we've hampered on the consultation services. We've hampered on the screening services in terms of monitoring of blood pressures. We've hampered on the investigations in terms of the labs and other imaging services. We've definitely hampered on the services in terms of the drug and prescription refills. We've also done a lot of shutdown of rehabilitation services. We've also done shutdown in terms of education, nutrition, and counseling. And that's where that's where now the rubber meets the tar. Let's go to the next slide. Okay, so traditionally, ambulatory care has been disrupted, like for real. It has been a lot of disruption. Everyone is focused on COVID, and many patients are delaying. There is first delay in referral. There's first delay in seeking health care. There's also including palliative or preventive care. We've delayed everything. Look at our indicators for essential health services, which is a CES. continuation of essential health services. And this is what all the policymakers are now looking at. They are telling us, look, we've done a lot in terms of this, but what about the essential health services? What about the procedures, the orthopedic procedures that we've hampered before? What about the drug refills that we've not done? We focus towards the response of COVID. This has compromised a lot of triage of non-COVID patients. Cardiovascular diseases are now coming in as emergencies. We now have COVID infection with longer term implications for overall cardiovascular health and non-communicable diseases. We don't know what this COVID has done in the long run. Everyone who was at COVID, they did ECGs for patients with COVID, even them with mild disease. They ended up having a lot of myocarditis, Takasubos, and also dysrhythmias, but they didn't have any severe disease. But what's the long-term effect of that? What will happen later on? What has this COVID done to the patients with hypertension in the long run? And now we've hampered all these services. We've seen a significant rise in the excess mortality. And every time we have increase in the excess mortality, we also have increase in the COVID cases or COVID mortalities. But the difference between the COVID mortalities and the excess mortality is so huge that people are trying to think and say, maybe that excess mortality that we are seeing is due to the services that we've hampered, or it might be due to the COVID itself. So there is a lot that we don't know behind the scenes, and we really need to think and zoom down into the data and try to reason, can we integrate these services? Can we start now bringing COVID to the other non-COVID diseases? Next slide, please. Okay, so the COVID pandemic has shown that we have alternative viable plans for providing healthcare services to the most vulnerable population. All we need to know is, where is the most vulnerable population? And how are we going to know that this vulnerable population has to be taken care of? We need to decentralize the planning of drug delivery. And this is key in communicable disease control. First, it's early identification. We need to early identify these patients with diabetes, hypertension, and obesity, so that we know where they are. And then next, we need to now decentralize the drugs if we have to treat them. And then I'll come back to management and talk about the lifestyle modification and all the other integrated community volunteers and services that we should work with. Next slide. So here, what I was trying to say is, we need to have a dedicated team of volunteers ready at hand to work hand in hand with the community and to work hand in hand with the community healthcare workers. We know that there is vaccination going on. We know that the screening, we can combine the screening of non-communicable diseases like hypertension. We can do BP screening with a patient with the same team that is doing vaccination. We can also decentralize the drug procurement and the logistics. We can use the same patients that are doing the vaccination. They can be the same people that are doing the vaccination. They can be the same people to deliver the drugs. Because remember, Gogo in the village has no access to the hospital now, because you are now chasing away Gogo. No, there's COVID, go away, go home. We'll see you after 6 months. But you haven't given him the drugs to go and control the hypertension. And the moment she gets hypertension, then the moment she gets COVID and she already has uncontrolled hypertension, then it becomes a problem. So this model can be implemented on a large scale in the future, and this doesn't involve an extra human resource because we already have. So on the next slide, I've tried to put in the already existing structures that we can use. We can use the village health nurses, we can use the mobile medical units, we can use the human health volunteers, we can use the trained community volunteers to integrate the services of drug delivery and also integrate the services of control of these of hypertension, of non-communicable diseases. We can use the palliative care patients, the bedridden, the geriatrics, and all other. But we need to create a line list of all non-communicable diseases so that we know where the patients are and we know how to distribute these drugs and how to integrate the health services. Okay, next slide. So let's pause again and allow Dr. Mawela to run us through, state whether this statement is true or false. Hypertension is 100% not curable. Or treatable, sorry. Quite a good question. Great. So 81% of people say, that's false, man. And about 19% is saying, maybe it's true, maybe we don't treat it. You know, we've always failed to treat it. I mean, we failed to do that. Okay, great. I'll answer that as I go through the slides in the next maybe 5, 6 slides. Classification and types of hypertension. So we know that there's primary versus secondary hypertension. Over 90% of cases are under primary. These are known causes. We don't know what the causes are. They develop gradually over a longer period of time, and they've got multiple associated risk factors. We talked about them: tobacco, alcohol, sedentary lifestyle, family history, age at its best as well, and stress. And then we know about the 10% or the less than 10% that actually account for secondary hypertension. This hypertension, we know the specific causes. We know that it's sudden, it happens, it's very severe, and it's usually refractory, may occur in young patients. This is what we call the young hypertensive patients. Okay, next slide. And we know the causes. Some of the causes of hypertension are actually well known. And in more than 90% of cases, yes, we might not know the cause, and that's what we call primary or essential hypertension. But in 5 to 10% of the cases, we actually know the causes, and that's what we call secondary hypertension. And that is treatable, because once we know the cause, we can actually sort it out and we can treat the patient. Okay, next slide. All right, so we talked about these the causes of secondary hypertension. Of note, you can see that adrenal diseases like pheochromocytoma, once you get it, you can do the CT scan, locate where it is, remove the tumor, and it's sorted. With causes like coarctation of the aorta, you can go and dilate the aorta mechanically or operatively and sort it out, okay? And also causes like drugs, you know, steroids, estrogen, sympathomimetics. You can stop the drugs and the hypertension is sorted out. So some of the hypertension is, so actually the question previously is actually false, because part of the causes of hypertension, we actually know them and we can sort them out. And the metabolic syndromes, we can control them. And the other types of hypertension, I think, which we are all familiar with: isolated systolic blood pressure, white coat hypertension, and resistant hypertension, defined as blood pressure more than 140, despite a treatment with at least 3 drugs, including a diuretic, and inadequate with adequate dosaging. And after that, you still think the patient is still having blood pressure more than 140/90, and then you can say, I think they are having persistent hypertension. I think these are things that we are really well familiar with. Next slide, please. And then here, I just wanted to give a bit of the staging of blood pressures. And I gave normal blood pressures, high blood pressure, stage 1, mild hypertension, stage 2, moderate hypertension, and then stage 3, severe hypertension. Okay, next slide, please. Great. Here, we just wanted to look at what are the other presence of any other of the following significant increase in cardiovascular risks. A patient who is hypertensive and diabetic, they're in trouble. Hypertensive with chronic kidney disease, in trouble. They've got a stroke, myocardial infarction, peripheral arterial disease. They are still smoking. They've got dyslipidemia. Their risk of dying or even severe disease with COVID even significantly increases. I just wanted to give a few symptoms of hypertension, which I think we are all familiar with. Chest pain being one of the biggest things, difficulties in breathing, which I'll come back to, hematuria and palpitations. I think I'll also allude to them as we go down through the presentation. History becomes very important. So in the history, you are aiming to exclude the possible risk factors. So you want to look at the risk factors. You also want to look at the complications and the associated complications. That's what you are really focusing on. And not any presenting complaints, you need to take a good detailed history. What are the presenting complaints? What's the history in terms of smoking, alcohol use, family history of cardiovascular diseases, past medical history, history of elevated cholesterol, diabetes, and current medication. Remember, NSAIDs are also part of the causes of hypertension. So current history of medication, also the past medical history is also very, very important, right? In terms of examination and physical general examination and systemic examination, I think we are all familiar with clinicians. We see from patient to patient, it's different how we examine the patients, and this is directed by which complaints and what systems you have affected and what you are looking for. But I think we'll also shed more light as we go down. Thank you. Next slide. Here, I just wanted to give what are the BMI cutoffs, and it's important to really get the blood pressures and also get the body mass index. In the study that we did looking at the mortality of patients in Mpumalanga, and we wanted to estimate the issues of obesity, we found that all the 80 FAWs of patients that we audited, no one actually had a weight taken, a weight and a height taken. So there were a lot of obesity that we were missing. So it's very important that the weight of the patient is taken, the height of the patient is taken, and you calculate the BMI so that you've got at least a cutoff on where you are looking at when it comes to physical examination of patients with hypertension. Next slide. Okay, great. Here I wanted to give a few mandatory investigations that should be done in patients with hypertension. So on the first column, I've given the investigations. On the second column, I've looked at the target organ damage. What are you looking at? If you're looking at target organ damage, and I'll explain the target organ damage, keep it simple and keep it straightforward. Just look at the head, think about the brain and the head, okay? If you go down, you go to the chest, look at the heart, the lungs, and the blood vessels. If you go down to the abdomen, look at the kidneys and look at the blood vessels again. You go down, if you're looking at a female, you look at the bladder. And those are the target organ damage. It will affect the brain, it will affect the eyes, it will affect the heart in terms of ischemia or arrhythmias or anything. It will affect the lungs in terms of the pulmonary edema. It will affect the blood vessels in terms of the dissection, aortic dissection. It will affect the kidneys in terms of renal failure, proteinuria, and blood in the urine. And those are the things that you should be doing: urine, proteinuria, creatinine, renal failure. And then it could affect the uterus in terms of the preeclampsia. Okay, and those are the things that you should be dwelling on. And then in terms of risk stratification, you know what to do. In terms of the secondary causes, you know what to do. Okay, so those are the mandatory investigations and when you should do them and what you are looking for. Okay, and to me, I think this is a very important slide. Okay, great. Let's take a short break, pause down, cool down things, and think about the poll question. Effects of lifestyle intervention on systolic blood pressure includes the following. A, exercise. It reduces 5 to 10 millimeters of mercury of systolic blood pressure. Weight reduction. It reduces 1 to 2 millimeters of mercury per kilo reduction in weight. Alcohol intake reduction. 1 millimeter of mercury per drink per day reduction. Sodium intake reduction. 1 to 3 millimeters of mercury per 40 millimoles per deciliter of sodium reduced. E, all of the above. What's your answer? Yeah, tricky one, but I think we're doing very well. 92% says all of the above. 11% think only D, okay? Well, let's go with it. I think it looks good, and I think we're doing very well. Now we are going to management, and this is where we're. Treatment approach. I can tell you the biggest treatment approach to management of hypertension is just lifestyle modification only. The rest of the things down here are just to maintain things as we go, But lifestyle modification stands a huge chance of you controlling that blood pressure. hypertensive therapy, treatment of all risk factors. Statins should be considered in every patient. Aspirin for secondary prevention and only for very high risk or primary prevention. BP must be controlled at least 160 to avoid cerebral history. We know that, but lifestyle modification is the huge thing. Next slide. So here I've tried to list all the things that I listed in the poll question and what we should do. And this is really, really true. Behavioral intervention with stress management, that is very important. Support with tobacco cessation, physical activity. But I love the next slide more. Great, this is actually true. Exercises alone can possibly lead to about 10 to about 5 to 10 millimeters of Hg of blood pressure drop. And alcohol alone, about 1. Weight reduction, 1 to 2. Sodium intake, about 1 to 3. And that's very important. It's all about lifestyle. Once you control, and every time you're treating these patients, your first intervention should be first lifestyle modification. And then you can play around with the drugs, you can play around with all these other things. And a little bit of a crowded slide, but I think this is a very good slide that you can just pick up, print it, and put it on the wall in the clinic or in the hospital, and then you can just follow the step by step up to step number 7, where it just gives you what you are going to do, what investigations you're supposed to do, what are you looking for, and also just exactly what you should be targeting, what's your blood pressure target and everything. And I'll leave that slide just the way it is. And I'm sure I will encourage you to just print this page and put it in at the wall and look at it, because it summarizes every little thing that we've talked about in the last 40 minutes. Next slide. And also here, I've given all the drugs that we are using, beta blockers, ARBs, all the drugs that we are using in the management of treatment of hypertension, and I've given their classes, their dosages, and sometimes the possible complications. This is also another slide that I'll just want you to go there, look at it, and see which one are you going to inhibit. And please look at the National Department of Health, South Africa, treatment of hypertension, which drug you start first, how do you go about it, how do you titrate. Next slide, please. So these 2 slides, I can give you time to go through. Okay, let me just give a little summary in terms of when it comes to SE inhibitors. So many, you remember when COVID started, people were talking about SE inhibitors and how it will affect the COVID because they're using the same receptors. However, they were by then, when this slide I think was formulated, there were no big studies that really shown a relationship between COVID and also severity of the disease in terms of patients that are on SE inhibitors. And that's why on the next slide, please. The WHO scientific brief in May 2020, they said, I think the conclusion is that these medications should be continued. And this, I think, stands up to now. Patients that are on SE inhibitors don't stop the SE inhibitors. If they're doing fine and you're able to control their blood pressures on SE inhibitors or ARBs, continue. Don't stop them. There is no effect. There is no correlation between severity of the disease and the medication that these patients are on. All right. Next slide, please. Great. And then here, I just wanted to give a few indications when it comes to immediate physician consultation. Hypertensive patients who are aged less than 18 years, those are very high-risk patients. Hypertension, blood pressure more than 180 systolic with a diastolic of more than 110, you need to consult a physician on what to do. And I will dwell on that when it comes to talk about the clinical scenarios. Secondary cause of hypertension is also a suspect. All pregnant women with high elevated blood pressure are also a high risk for you need to consult the physician, you need to consult the obstetricians or gynecologists. And also pre-existing diabetes with hypertension is also another issue that you need to look at. Newly diagnosed diabetes with hypertension is also another issue. Heart failure with hypertension is always a red flag because these patients might have been having left ventricular dysfunction or right ventricular dysfunction. They are now in heart failure. They can go into pulmonary edema. Abnormal results on urine dipstick can be the only thing. We actually found that more than 70% of the patients that came in with renal failure in the emergency department actually had blood in the urine. So just a simple urine dipstick can actually give you a lot of information and referral of these patients. Okay, patients not reaching goal blood pressure after 4 to 6 weeks of trial medication. You've started them on antihypertensives and they are not reaching. Consider referral for patients aged above 80 as well, with a first diagnosis of hypertension. Very, very, very red flag. Okay, next slide. Great. So you need to introduce the drugs one by one. And I think this is all written in the South African guidelines in terms of management of hypertension. They've really given a comprehensive approach. Start with one drug, start with this, then titrate to maximum dosage before adding another drug. And then if inadequate response to agents, consider consultation with a referral to an experienced clinician in the management of refractory hypertension. That's very, very important. All right. Next slide, please. And of course, hypertensive emergencies. And I was trying to push things so that we get here. And so a lot of people define hypertensive emergencies just by the number. Elevated blood pressure, 108 over 120 or more associated. But I think for me, the biggest issue is end organ damage, organ dysfunction. If there's just organ dysfunction, even if the blood pressure is normal, in a non-hypertensive patient, it's still an hypertensive emergency. They can have hypertensive encephalopathy, hypertensive left ventricular failure, hypertension with myocardial infarction. And I've talked about it. End organ damage, keep it simple, go straight, look at the head, the brain, and the eyes. Look at the chest, the heart, the lungs, the blood vessels. Look at the abdomen, the kidneys, the blood vessels. Look at the pelvis, the uterus in females. Okay. If you talk about the lungs, pulmonary edema. If you talk about the heart, ischemic heart disease, dysrhythmias, arrhythmias, and all that. If you talk about the brain, it could be a ischemic stroke. It could be a bleed. If you talk about the eyes, it could also be an ischemia in the posterior with bleared vision, or it could be all the other issues with cataract as well as part of the diabetes patients. So really keep it open and keep it simple. But how do you treat hypertensive emergencies? And I think this is where the next slide comes in on the scenario based. And I've deliberately left the last 30 minutes so that we can just discuss these scenarios. Okay. I'll come back to them, Dr. Mawela. Let's go to the next slide. I think the last 30 minutes, as we discussed, will flash these scenarios. Okay, so management of hypertensive emergencies, other than in pregnancy, if the patient is conscious and they're able to swallow, give them oral long-acting antihypertensives and consult with a physician on a plan of management. If the patient is GCS 1515, I'll come back to this when I discuss the first scenario. And then if the patient is unconscious, refer them immediately to a facility where they can do a CT scan, or they've got a capability for proper evaluation of this patient, because they need to know whether it's a stroke or it's an ischemic stroke or it's a hemorrhagic stroke. Next slide. Great. And always remember, there will be these mimics to hypertensive emergencies. Other conditions that may present as hypertensive emergencies, the crisis associated with pheochromocytoma, very, very common. And one of the other commonest is recreational drugs, cocaine, amphetamines, these ecstasy. All these patients who come in with elevated blood pressure, chest pain, ECG, you do an ECG, they will even have ST elevations, okay? Hypertension perioperatively, severe preeclampsia and eclampsia, I think I alluded to that. And there's also a scenario on that. Head injury with the intracranial bleeds. These are really, really important. You look at the history, the guy fell from a truck or he was beaten. Then there's also uncomplicated raised blood pressure with no end organ damage or no associated end organ damage. This is often associated with treatment discontinuation, reduction. So people just come in elevated blood pressure, 220 over 180, and they tell you, nothing, I'm okay. I can see you, GCS 1515. Yeah, I stopped the medication 2 months ago. Then you know what to do. And then it should also be considered as an, so we don't need to consider those guys as an emergency. We optimize their drug therapy and we treat their anxiety. Actually, the emergency book, emergency medicine book, Rosen, says find a dark corner in the emergency department where you can put this guy in a quiet, dark corner. I've never seen that corner in the emergency department. I've never. There's always chaos in the emergency department. And then I also wanted to give, how do you refer these patients? It's very, very important. The name, the designation, the signature, the contact details, the address and phone of the patient who is referring is very important. You never know when you are going to give a vital information to the one that is receiving the patient. Write as much as you can, get as much details as possible. Some of these patients will be referred with a stroke. Some of them, they won't even go and talk at the facility where they are going. So you really need to refer these patients with as many details as you can, and also list the medication that you've given and give your working diagnosis. If you're not sure, just say, this is what I think. Let them go and sort out at the hospital. But it's very important that you give your clinical findings, you give your laboratory findings so that they don't unnecessarily repeat the tests, and give the list of medication, and also just the reason why you are referring that patient, because sometimes it might give a different clue to the one that is seeing patients on the other side. And I think this should be the last patient, Doctor. This should be the last slide, Dr. Mawela. Yes, now let's go back to the scenarios. Perfect. So I deliberately left this time for the scenarios. Now, I would want someone in the audience to just tell us, or anyone, to just tell us what they can do. They've got a 28-year-old male with elevated blood pressure of 190 over 110, all the other vitals are normal and is COVID positive. Over to you, Dr. Mawela.
Yes, Dr. Segola, can you help to facilitate this? I'm not sure if these hands have been up for a while. Colleagues, if you want to engage on case one, please raise your hand. We want to give you some audio, but I want Segola to be involved. Thanks.
Yeah, no problem. I think the question is all up there and clear. I haven't seen any hands raised. Let's just give people a chance to go through it and think it through for about 30 seconds. 28-year-old with elevated BP, 190, 110, all other vitals normal, and COVID positive, right?
Yes.
Maybe we must ask Mawela to take it on.
I like that.
If you convert it, if you give me the HIV status, I'll help you. Okay, Maria Smith, would you like to try? I thought I saw Maria.
Feel free, no wrong answers. Everything is good.
Maria, would you like to try? You can
unmute. Okay, no, I just must get unmute.
Oh.
Okay, first of all, it is a younger patient. The first time I have no history of blood pressure.
Yeah.
So we will assume that the blood pressure is related to the COVID. I would, because we're not sure whether the COVID would further elevate it and cause complications, I will try to treat the blood pressure as soon as possible.
Okay, so what are you going to use to treat that blood pressure?
Oh.
Which drug are you going to give, if you're going to give a drug?
Well, I'm a supporter of ACE inhibitor, sorry.
Okay, I like that. The boldness is good.
Because first of all, it's a young man.
Yes.
And it's proven that the ACE inhibitors is not totally contraindicated in COVID cases. So
exactly.
I will give it a go. I will not go for diuretics.
Okay.
It interferes too much with the electrolyte balances, so it's not advisable. That's my opinion.
Excellent. Excellent. Remember, yes.
Yeah. Before you comment, just to encourage everyone, please, you can also type on the chat if you want to type in your answer in case you have a phobia for raising your hand. Yeah, you may continue, John. Thanks.
All right, perfect. This is really, really good. And this is really important. Remember, the first question that you should ask yourself is this guy an hypertensive emergency or an elevated blood pressure with no target organ damage? Once you answer that question, then you know where to go. This guy, yes, is a young guy. He has elevated blood pressure. He has COVID. We're worried about him. Don't lower down that blood pressure quickly. If you give him an SC inhibitor like nifedipine, this guy is going to die in your hands. Never treat it. Take your time. Investigate him. Know what the problem is. Get an ECG, get a urine dipstick, get the U1Es, do the chest X-ray. Take your time. His GCS 1515, all the vitals are normal. He's not dying in front of you. This is a guy that you take your time. This is a guy that you don't rush to treating him. Investigate him. Take your time. Investigate the young guy. Okay? Get as much history as possible. Wake him up fully. Do a full wake up. The full wake up is mandatory in this guy. Before you even touch any drug, get a full wake up. Try to see what's going on. Take your time. Okay? Whether it's COVID or it's non-COVID, take your time. Okay? The issue here is take your time. Don't give him an SE. Don't give him a calcium channel blocker like nifedipine. You're going to kill this guy. Okay, but I agree with you. You can give him a long-acting calcium channel blocker. Is okay. You can give him a long-acting SC inhibitor, but take your time. He's not an hypertensive emergency. He's just an hypertensive. Is an elevated blood pressure with no target organ damage. All his other vitals are correct. Maybe he's obese. Maybe it's just because of the COVID. Maybe, you know, but this is a guy that mandates you to give him a real full wake up. All right. Okay, great. Dr. Joshua, you had something to say?
Yeah, I was saying certainly in the chat box, Dr. Bokosh is agreeing with what you're saying. Actually, he had actually typed it before he says this is a gentleman is very young. History is very important. Previous history before COVID, family history, risk factors, history of malignancy in the family, and a full wake-up is mandatory. It's actually concurring with what you're saying.
Please investigate, doctor, because he might be tapping in my brain.
Yeah. No worries. I see an end of Daphne and Michael Larrick and Anthony Moore. I don't know if they are already in the next case scenario or they're still.
Yeah, that will even be good if they're in the next case scenario. Next one, 45-year-old male with chest pain, difficulties in breathing, with elevated blood pressure of 210/120. Let's go for it.
All right, Michael Larrick.
Try Kuba. I can't see the full name here. You may
Michael has hand up and I think he's unmuted as well. We can unmute Michael.
Yeah, Michael is unmuted. Michael, you can go.
It looks like he's still muted.
Please unmute if you want to make a comment. All right.
Daphne Cuba. You need to unmute your mic to speak.
There you go.
There's Daphne.
No, I've muted that one.
Anthony Moore.
No, I think I'm gonna lower all the hands so that the people can raise their hands again if they really want to engage. Yep.
Okay.
Yeah.
All right. No problem.
Some of these might be just
a false hands.
Yeah.
All right, Dr. John, you can take us through.
Okay, I've seen there's a chart there. I think priority is to relieve the shortness of breath and observe the blood pressure when respirations become better. That's WADA. Okay, I wish WADA can have more to say there because there's a lot on this guy. Okay, Relato Pato is saying give oxygen, nurse in semi-polar position. Temba is saying also refer to a psychologist. I like that. But hey, a 45-year-old male, chest pain, difficulties in breathing with elevated blood pressure of 210 over 120, COVID positive. This guy is in trouble. This guy is anything. Remember, we've got the head, we've got the chest. And in the chest, he has chest pain. Already he has target organ damage. And then he's got difficulties in breathing. So he's got target organ damage in the heart. He's got target organ damage in the lungs as well. This guy has pulmonary edema. We don't know what his SATs are. Maybe the SATs are in the boots. We don't know what his chest pain is. Is it a blood? Is it the heart? Is it the blood vessels? This guy is in serious trouble. This is the guy that needs a proper emergency care. You have to give oxygen to this guy, put him on monitors, give him something that lower down that blood pressure. And if you're thinking of the chest pain and the difficulties in breathing as being part of the heart and the lungs, this is a guy that needs at least TNT, nitroglyceride. You need to lower down that blood pressure. You need to increase that perfusion to the heart. Maybe this is an ischemic heart disease. That's why there's chest pain. Maybe this is pulmonary edema. That's why there is that difficulties in breathing. You need to lower down. You have to lower down the sympathetic charge that he's having. Maybe it's just a sympathetic charge that is causing that blood pressure. So give him nitroglyceride. You lower down your venous return. You also lower down your systemic peripheral resistance. That will help you to lower down that blood pressure. That will also help you to cause coronary vasodilatation so that you increase the blood perfusion to the heart itself. This is a guy that could also benefit from NIV or oxygen using the NIV, because the NIV increases intrathoracic pressure, pushes the fluid out of the lungs, and improves the breathing. So I agree with you guys who are saying give him oxygen, but this is a guy that I'll give at least a TNT to lower down the venous return, and also to lower down the systemic vascular resistance, so that I lower down. This is a guy I want to lower down that blood pressure. Okay, but of course, chest X-ray, ECG, full history, full workup. But this guy is an emergency. Okay, this guy is different from the first one. This one is a proper hypertensive emergency with end organ damage. Okay, so now you see where the difference is. You have to make that distinction before you kick in. All right, great. Any other issues? And I think because Dr. Joshua, you can pick it up, but I think he's still tapping in my brain.
Yes, it's still tapping in your brain. But before we go to the third scenario, I just had a question from the audience while we are at this kind of a scenario. Maybe we can entertain it. It says, if hypertension is well controlled with medication, is it still a risk factor for COVID infection and the mortality thereof?
Not really a risk factor for infection, because remember, the risk factor for infection, we know. It's non-compliance to non-pharmaceutical intervention, movement, being in a crowded place, and everything. But yes, it is a risk factor for progression to severe disease. Controlled, especially the uncontrolled. I don't know if there is a large meta-analysis on the controlled patients with controlled blood pressures or controlled hypertension. I don't know if you have any studies looking at the patients that are well controlled, Dr. Joshua.
No, I don't have any that I've
my sense is that, yeah, no, I wanted to say my sense is that study would not have a huge impact, because you said that around 8.9% of all the cases are controlled. So even if they say controlled, the majority of cases are uncontrolled. So that's why this topic, the public health approach, we don't just want to talk about COVID. We need to talk about why it's important to ensure that all hypertensive patients are controlled in the first place before we talk about COVID, because COVID just shows us things that were going wrong anyway.
Yeah, and I think if the patient is well controlled, the chances of them progressing into severe disease are less than those that are non-controlled. Yeah, but there are a lot of studies that have shown non-controlled progression to severe disease and death very, very high, just like we've given all the data in the presentation.
Thank you. And a follow-up to you and Dr. Mawela, it says, does COVID-19 actually do cause hypertension, or it unmasks it? Why do we have so many patients post-COVID presenting with hypertensive agencies or emergencies?
Dr. Joshua, I think I'll tend to agree with that question. I'll tend to say yes. I think it does both. It unmasks the hypertension that we didn't know, and it might also cause hypertension. Remember, it has an effect on the blood vessel, and it also has an effect on the myocardium. So there's a likelihood that it might actually induce the hypertension due to the effect on the myocardium. It can cause myocardial insufficiency. It can cause myocarditis. It might cause these dysrhythmias and arrhythmias. And also on the blood vessel, it might cause endothelial damage, leading to propagation to a clot or a plague, and leading to narrowing of the blood vessels and increase in the blood pressure. We know it has the effect on the kidneys. It causes renal failure. And once you have renal failure, you can have hypertension as well. So I'm tending to say yes, though I don't have the actual studies and data to show that.
In the very same breath, COVID-induced hypertension, will it lead to chronic hypertension? I haven't seen any study. I don't know if you have seen somebody looking into that. Post-COVID really. Hypertension, then you develop a long sequelae of hypertension.
Of hypertension.
Chronic. Have you seen that?
I don't know, Dr. Mawela, if he has anything.
No, not that I know of. But the question is, I think underlying that question is, if you decide to treat the hypertension, are you treating your patient as a forever, or you're only treating them during the acute phase of the disease? My sense is that the treatment is never stopped, right? Am I correct?
Actually, that's one thing that we are yet to understand, because we don't know what the long sequelae will be. And I want that question to be asked to Dr. Madua next week about diabetes, because it's the same scenario.
I'll keep it for him.
Please.
I don't know if he's in attendance. In relation to scenario 2, Noctuna Mapumula has got something here interesting that she says, I can't wait for a response. On Saturday, I had a patient presenting with elevated BP, 222/121, audible wheezes, bilateral crepitation, saturation of 89 and on room air, and pitting edema, but COVID negative. I did urine analysis, protein plus, blood 2 plus, euro 2 plus. I administered NEPs and put him on oxygen. Furosemide 20 milligram IVR slowly given. BP was still elevated, and it was discussed with the receiving doctor since my patient refused to be referred to the hospital.
Absolutely, 100% perfect. That guy was having pulmonary edema. You can see from the SATs, you can see from the bilateral crepitations. He has wheezes because he has fluid in the lungs. That guy is a proper hypertensive emergency with complications in the lungs. Okay, that's one thing. And then he has already edema, pitting edema. He has heart failure as well. Okay, so the heart failure can also concomitate the pulmonary edema and everything. Furosemide, I agree with you. Oxygen, I agree with you. The way you worked out the patient, I agree with you. Being COVID negative is not really a big issue. If he was COVID positive, thank you. It's COVID, it's hypertension with COVID. If he's COVID negative, treat him as a hypertensive emergency with pulmonary edema and cardiac manifestation and heart failure.
Noted. I think we've got 2 hands that we could take. Christopher Isema.
Yes, hello, good evening all.
Good evening.
Please, I want to know, how soon after COVID-19 infection have you seen people having hypertensive sequelae? How soon does it develop? Is it an acute thing, or it's something that comes over time? If it comes over time, we don't really know. That could have been incidental. Maybe that person was supposed to have high blood pressure from probably,
something else.
From maybe, maybe he's obese or something like that predisposes him for hypertension. So how soon after do we see hypertension developing, from COVID-19?
I agree with you, Christopher. I think let's put one thing straight. The blood pressure that we are seeing that is elevated might be COVID or might not be COVID. And let's start from there. Is it COVID? Is it not COVID? And the time frame, we don't know. Some people who have the same elevated blood pressure in the first 4 days. Some people who have elevated blood pressure because of their already pre-existing hypertension from a long time ago. And that's why I'm saying this COVID negative should not take you out of the picture. Treat the patient. Treat what you have. Whether it's COVID related or non-COVID related, it's not really a big deal. It's the same thing that Dr. Madua will tell you when he comes next week. He will tell you there's elevated glucose. Whether it's diabetes type 1 or diabetes type 2 or it's COVID-induced diabetes, you have to treat that elevated blood pressure, elevated sugar. And then the complication comes in when you even start steroids, because now you're thinking it's COVID. Now I need to start steroids. Then your sugar even becomes a hell way to control. Even when it comes to blood pressure, it's where the issue is. If it's COVID, now I need to come back and say, okay, let me start with the steroids. Let me start doing this for COVID. Let me prone the patient. But if it is not COVID, let me go with the default. It's an hypertensive emergency. COVID is just coming in to distract me. On the time frame, difficult. I don't know, Dr. Joshua, anything else on the paper?
Yeah, on the same breath, in terms of saying it's COVID hypertension, will that be by a diagnosis of exclusion of the common risk factors that we know to have been mentioned to cause the hypertension, or is there any direct link?
Yes, that's another good question that we don't have an answer to.
So most likely now we'll be relying on diagnosing it by exclusion of the obvious
diagnosis of exclusion.
We don't.
But the most important thing, I think, one thing that we should take out, one thing that we should take out is let's treat the hypertension correctly. Then we can deal with COVID later.
All right, good. Dr. Mawela, do you still have 1 minute to go to the last scenario? I don't know.
We still have a few minutes, but I would really love John to run through these cases and give guidance. Maybe we can even take guidance from some of the comments. But I think if you can just go through the last 3 cases, just giving guidance on what you think would be done. And then we'll see in the last few minutes if we still have time for other hands and comments. We need to wind up at least by 25 past. Yeah, thanks.
Perfect. So scenario number 3, 71-year-old with blood pressure of 220/120, GCS of 815, sudden onset. This guy is a stroke unless proven otherwise. So it's a hypertensive emergency with a brain target organ damage, okay? So this guy has to be investigated fully. In the investigation, this guy needs a CT scan. You cannot do without a CT scan. You need to know, is this hemorrhagic versus ischemic? If it is, you scan him and you find that it's hemorrhagic, you lower down that blood pressure. Okay, Atachi 1, Atachi 2 trial. You lower down the blood pressure, you decrease the increase intracranial pressure, you decrease the hematoma size and all that. But you need to lower down that blood pressure if it is hemorrhagic. If it is ischemic and you are worried about the ischemic penumbrum of the brain, then you keep the blood pressure above 160 but less than 180 in the systolic, above 90 but less than 110 in the diastolic, and lower down that blood pressure slowly, because you are relying on that blood pressure to perfuse the ischemic penumbrum in the brain. And that GCS is low. So someone will ask me, are you going to intubate this guy? Are you going to, but I'll tell you, no, this guy is GCS 815, is able to hold his airway, but the scan is what he needs. He's begging for a scan. You cannot give this guy an antihypertensive, or you cannot treat this guy without a CT scan. You need to know what's going on in that head. Okay, that's what I wanted on this scenario. You need to know. I need to scan this guy. I need to know whether it's hemorrhagic or ischemic, and then I do something on the blood pressure, or I keep the blood pressure in these limits. So remember, Atachi 1 and Atachi 2 trials that looked at ischemic versus hemorrhagic strokes, and the blood pressure targets in these two categories. 34-year-old female, elevated blood pressure. Yes?
As you go through scenario 4, there's 2 comments already which I need you to pay attention to. The one deal and Diakanyo on case 4. Mr. Zondi says proper history taking, systemic address. He says abort and prevent further seizures. And you do pregnancy test to exclude eclampsia. Then manage accordingly. Diakanyo says, is she pregnant? Now there's a question about pregnancy and stuff. So
this one is a good one.
That, yeah. You can read the case and then take us through. Yeah.
Sure. This one is a good one. 34-year-old female, elevated blood pressure of 160 over 100, fitted twice before presentation to the clinic. This is eclampsia unless proven otherwise. Anything that you are going to tell me, if you don't ask me whether she's pregnant or not, then I'm still waiting to hear from you.
Yeah.
Okay. This is the lady that gets a pregnancy test first thing, gets a probe on an ultrasound on the abdomen and find out whether she's pregnant or not. If she's pregnant, the route goes to MAGSAF and all the other things. Okay. She's not pregnant. She goes to CT scan as well. Is it hypertensive encephalopathy? What are we dealing with? Is it a bleed? Is it an ischemia? But I brought out this scenario because I wanted someone to ask, and I like it. Is she pregnant or not? Yeah. That's what I want to hear. That's all. That's the first thing you need to tell me. She's not pregnant, then I'm happy.
I see Dr. Ilunga says, if pregnant, do everything including MAGSAF. So I want to ask you, if she comes in fitting, Doc, are you gonna wait for the pregnancy test, or are you gonna give MAGSAF and then check the pregnancy test? How does it work?
That's a difficult one, Dr. Mawela, but I'll go with a probe, ultrasound. It's easy. It's me controlling it.
Where is it? She's fitting.
Put the ultrasound there, boy.
All right, it's fine.
Put the probe there. She's pregnant, MAGSAF.
Okay.
And then you go
ahead. Many casualties have soda nowadays. They still have to push the patient somewhere to a sauna room.
I know. Dr. Joshua is my witness here. But that's why that scenario was brought up. Let's find out if she's pregnant or not. And let's go ahead with the algorithm as we go. Okay, she might need a CT scan later on if she's not pregnant. If she's pregnant, we are going down the route of eclampsia. That's what we want. But of course, there will be other investigations that need to do the liver, the kidneys, and all that, which is straightforward. But first, make sure she's not pregnant. 82-year-old female with normal vitals, GCS of 11-15, being brought down by the verbal. She has weakness on one side of the body. This one is an ischemic stroke, but don't rely on it. It might be a bleed as well, but she needs a scan.
And there's a question related to this. Malisela Sioko says, what is the difference in medical prognosis between hemorrhagic stroke and ischemic stroke? Because in OT, ischemic strokes are always better, or they always have better functional outcomes.
That's actually a good one. First, I'll ask them, which one is common, ischemic versus hemorrhagic? The ischemic are usually common. Which one do we see most in the emergency department or in the hospital? Hemorrhagic. So the hemorrhagic have got a very, very poor outcome. And that's why most of the time they present with a low GCS, a high blood pressure, whereas the ischemic one will present with normal blood pressures, but with slightly maybe even good GCS. And that's why they don't present to the hospital. Like this guy, the 82-year-old female, might not even come to the hospital on the same day. She'll come after 2 days or 3 days. But the hemorrhagic will come straight away. So the hemorrhagic have got a poor outcome compared to the ischemic, or one-on-one.
Yeah,
Sure.
Thanks for that. I also like Kisley Brown's comment to say history taking is very important. And she gives an example with case 4 to say you might put a probe, find nothing, but only that she delivered 2 days ago. And if you don't ask, you might not know. Yeah?
Perfect. Perfect. I like that. I really do like that.
Yeah.
And Dr. Vogt says, remember, you don't have luxury of city in rural areas, so history taking is still very important.
Excellent.
All right.
Thank you so much. And so many gray areas. You know, this is a new thing that we are not very sure about. But I think that my last message is that please put COVID on the side. Treat the hypertension emergency quite okay. Treat the elevated blood pressure as it should be. And then now come back and ask yourself, okay, what should I do now for the COVID? Remember, the emergencies will be there, whether COVID is there or COVID is not there. Thank you. And over to you, Dr. Mawela and Dr. Joshua. Thank you.
Thank you so much, Dr. John Masina. Quite informative and interesting. I like the scenarios, and the questions, Dr. Mawela. You need to find a way to make the questions available to the panelists as well. I've been answering in my head, and most of the time. And I got them wrong, but nonetheless, thank you so much. If you can really look and go back into the topic, we have covered 2 topics at a go, COVID and as well as hypertension or hypertension in COVID. This was quite interesting and eye-opener for me as a surgeon. I don't usually take BPs, but this was very interesting. Now I know how to deal with this also in relation to my surgical work. We really appreciate your time and we really thank you for your effort. And you can see this was well planned and well thought through and very informative and educative. We really appreciate it. Thank you so much, Dr. John. And Dr. Mawela, please, we've had a lot of comments and questions regarding getting the slides and some slides and the whole topic of the presentation. Please reiterate again to the attendees that members will only be eligible to get those slides and the topics like we have said in the beginning. If you can repeat it for us, and in the next seminar as well, please, if you can start with it. And also people are asking, how do we become members? When can we become members? And all those kind of things. If you can go through that again, I think it's very important. Okay, thank you so much. Good evening, everyone. Dr. Mawela, back to you.
Thank you. Yes, just in 30 seconds, colleagues, make sure that you attend not less than 60 minutes for you to be able to get your certificates. If we need to make corrections or you didn't receive your certificate, send us an email at info@clinicalcareplatform.com. Visit our website to review some of the training programs that we are working on. Our website is www.clinicalcareplatform.com. We are working on a number of interesting training programs. Those who want to become registrars to help you with part 1, those who want to write diplomas, and the bolded courses are already available. Before the end of the week, we will launch the drug-resistant TB course, and I hope that you would enjoy it. Just to say that from the 1st of January, when we start, please make sure that you are a member. So start now, subscribe now, so that you can continue to support our platform so that we are able to serve you better in terms of your professional development needs. Just note that there's 2 options, 12 months or 24 months membership. These webinars, will remain free. We are not trying to entice you. You'll be allowed ready to attend, but it takes time for Dr. John to prepare, and at the end of the day, he'll ask me, Doc, so what happened? So support us to support our clinicians so that we can also serve you better. Just to say that if you are a member, you'll be able to achieve all your annual CPD points without any additional fees. You'll get great discounts for if you want to enroll in some of our courses. You saw we were running the free course on HIV guidelines. you'll be eligible for such courses, you know, in the new year. We will continue to have good presenters. You can see Segola there. He's saying good presenters. Our sessions are informative. And you will have a library of topics, library of webinars, library of resources that you are asking for, guidelines, tools, you know, public workshops. So we look forward really to engaging with you. Just to remind you, next week, Tuesday, we are continuing, never mind the date there, diabetes mellitus and COVID-19. I think it's going to be a very powerful topic. I have listened to Dr. Madua dealing with this topic, and he has firsthand experience and also involved in a lot of research around this topic. Thank you very much. Good evening. Thanks, Dr. Segola. Dr. John, it's always an honor, my brother, for you to make time to be part of this platform. I think the colleagues really enjoy your talks as well. May all your dreams come true. Thanks, my brother. Thank you.
Thank you. Thank you so much, Dr. Mawela. And I'm sure next week will be great.
Yes, thank you.
Thank you, and good evening, everyone. Thank you.